Hello, everyone. Welcome to Tutor IMG's short medical series. So we're taking a look at antipsychotic side effects and continuing our discussion about those. And we're going to be considering our acute akathisia and acute dystonia reactions. So these are basically EPS, extrapyramidal side effects of antipsychotic drugs. Acute akathisia, as the name suggests, and of course, as the name suggests in acute dystonia as well, these are side effects that are manifested quite early on. So it's going to happen within a few days or within a few weeks of treatment. So early onset is one of the clues. Also, the way to recognize acute akathisia is that the patient complains subjectively of being very restless, right? This restlessness will be manifested in pacing around the room, inability to keep their legs still, right? They won't be able to keep the legs still, tapping on the floor and so forth. They'll have a general feeling of ants in their pants, right? Now, this feeling is very, very upsetting and can actually lead to a high risk of suicide. So, and this is seen usually also in older women. Older females are more susceptible to this kind of presentation. So what is the treatment for this condition? The treatment for this condition, first line, right, and this is very important for the boards, is to give the patient propranolol. Okay, so the first line treatment, okay, is to give the patient propranolol. Now, if the question mentions that the patient has just been started on the drug and, you know, is and says nothing more, then you might choose the option where it says reduced dose. However, most of the time, the question will mention that the patient has a resistant kind of schizophrenia and has now been put on this medication and is finally showing improvement of symptoms. So in that case, if improvement has been obtained through rigorous establishment of or choice of a drug, then reducing the dose might risk bringing the psychotic symptoms back. So it's better always to treat the symptom, the side effect of the treatment, rather than play around with the dose. If trying to treat the side effect of the dose doesn't help, then bringing down a dose might be an adjunctive action. So preferred answer on the boards, first line, propranolol. Second line is benztropine. Now, the other thing that we wanted to talk about was our acute dystonia. So what is acute dystonia? Again, the side effect will develop within a matter of days to weeks. And usually the at-risk people are male, young males, right? With a history perhaps of cocaine use in their past. So if you have such a patient, what can you expect to see in them? You can expect to see torticollis, which is a sudden, a very painful contracture of the neck muscles. Oculogyral crisis, right, in which the eyes will roll to the back of the head. Opisthotonus as well, very, very painful development of a bridge-like, posture in the body, with the head and just the toes touching. So young age, male gender, use of substances other than, of course, a medication like cocaine, and these can lead to the development of torticollis, oculogyral crisis, and opisthotonus in the patients on EPS. What do you do for these patients? Now, in this case, the treatment first line is going to be benztropine. Okay, choose the answer wisely, benztropine or diphenhydramine. Okay, benztropine or diphenhydramine. And if the patient's symptoms are extremely severe, both of these come in an IV prep, so you can give them IV suddenly as well, right? If not too severe, then oral preparations can be given. In patients who are first-time users and develop a very acute reaction, right? They might have used another antipsychotic in the past and gave a very horrible reaction. In those patients, if the question specifically mentions a previous bad reaction, then you might want to give the first dose in combination with kind of like an antidote. So say if you're using haloperidol, you might want to give the patient haloperidol in combination with benztropine, right? So that's a special circumstance in which the patient has already reacted poorly to another antipsychotic, right? So the treatment, as I mentioned, was to give this acutely. And then after this acute treatment, if the patient doesn't settle, you might want to consider switching to another antipsychotic, right? And if the switching isn't possible, because like I said in the previous question as well, the question mentions clearly that the patient is now stable finally on this dose, so we don't want to risk switching. What do? You will just add the oral benztropine, right, to the daily regime. So twice a day, right, twice daily, the patient will also take an oral dose of benztropine along with their antipsychotic. So thank you very much, guys, for joining me for this particular discussion. And for more videos like this, please continue to support our channel. If you want more details, you can always subscribe to our online course, which is available through our website, tutorimg.ca. So keep supporting us for free videos as well. Thank you.